I am Dr. Umer from. Assalamu alaikum, sir. I am Dr. Umer, a resident cardiologist from Sidhu Group of Teaching Hospital, Sawat, and I am presenting my paper here, which is titled as a rare and fatal complication of dengue fever, that is spontaneous coronary artery dissection. So we'll be going through introduction, case presentation, lab reports, angiography, discussion, and toward the conclusion then. Coming towards the introduction and background, dengue is, and as we know, dengue is an arbovirus infection caused by 4 dengue virus serotypes, and it is transmitted by the famous Aedes aegypti mosquito. It is an epidemic disease present in more than 100 countries and continues to spread worldwide with a predicted 30-fold increase over the last 50 years. Dengue fever can range from asymptomatic disease to potentially life-threatening condition that include dengue shock syndrome. Thrombotic events that worsen the condition in dengue patients are rare. Otherwise, the bleeding manifestation of dengue fever are pretty well known. So, coming towards the ECG, abnormalities in the ECG with dengue fever are common because of the low clinical suspicious score and coexisting clinical symptoms, including tachycardia, hypotension, pulmonary edema, and capillary leak, which are all associated with dengue virus infection. Cardiac activity in dengue fever is often underdiagnosed. So most of them show symptomatology. These symptomatology are temporary. Life-threatening manifestation involving the heart can be in dengue, hemorrhagic fever, and dengue shock syndrome, and these cardiac pathologies may be unnoticed, and these can increase the mortality rate of the dengue fever infection. So it is now known that there is an association, a high association between the dengue fever and heart involvement, which is around 13%. The study shows that. So coming toward the case presentation, a 45-year-old man presents with fever, retroorbital pain, bilateral leg pain, headache, muscular aches, abdominal complaints, cough, sore throat, nausea, vomiting in the emergency department. Interestingly, he had no comorbidities. Upon the arrival to the emergency department, he had a hematocrit of 45.3, while the platelets level at this time were 237. The dengue NS1 antigen was positive, while the ICT malaria was negative at this time. So these results lead to the diagnosis of dengue virus without any warning symptoms. IV fluids and oral paracetamol were given. The patient was consulted regarding the warning signs, and the patient was discharged to home. After 3 days after the patient being discharged, patient experienced sudden chest pain, and an ECG was performed which showed ST segment elevation in the inferior leads. At this time, his hematocrit was 47.8, while the platelets were 239. Meanwhile, a trop was sent, which came out to be 4.13, but in the meantime, the patient was shifted to the cath lab. So this is the angiography of the patient. Stop. इसको stop कैसे करेंगे? Stop हो गया यहाँ से इसके नहीं हो रहा है. So we can appreciate here. Let me show you another view. Here we can appreciate that there is a little haziness and disease in the LAD, in the proximal LAD. This is a clear view of the LAD where we can appreciate haziness. That is.
It's a mid LAD. Mid, not proximal.
Point नहीं कर रहा है. नहीं यार. This was the RCA of the patient, which was very, yeah. So here I have taken a picture of the LAD which shows the 60 to 70% haziness in the left anterior descending artery. This is basically a suspicious was a suspicious of SCAD, not leading to the diagnosis of SCAD. So this is the post angiography echocardiography, which shows regional wall abnormalities in the inferior area, while the left ventricular functions were preserved. At this time, the patient was having the patient was started on the guideline directed treatment for the SCAD, and repeat angio was performed after 4 weeks, but in the meantime the patient was closely monitored and observed for 2 weeks. After 4 weeks, this is the blood report of the patient, which showed hematocrit of 44.3, while the platelets were 433. So this is the angiography of this same patient 4 weeks after the initial angiography, where we can appreciate that the haziness has been resolved, and this is a normal LAD. I have also taken a picture of the same view. Complete resolution of the LAD haziness. The patient remained clinically stable during these 4 weeks period.
So were the platelets down initially, or what?
Initially the platelets were 233, then 237. When the patient came to the emergency department with the dengue complaints, the platelets were 233.
So is that the company?
Yes, but the dengue NS1 was positive, sir, at that time, and we were when the patient experienced chest pain, then the platelets were also normal around 237, but there was elevation in the inferior leads. So basically, we are correlating the SCAD with the dengue, sir.
What treatment he received?
The patient received for the SCAD, sir.
Whatever the treatment is.
Initially, he was given paracetamol, and he was counseled about the dengue warning signs, and he was told no brush and that related things about the dengue. And when the patient experienced chest pain and the angiography was performed, the patient was started on dual antiplatelet therapy and the beta blockers as the guidelines recommended.
How was the right coronary artery? Was that normal?
Yes, sir. I have shown just.
Yes.
I have just shown the right coronary artery. It was.
Why not? It was a simple acute coronary syndrome. Why did you think of SCAD?
Yes, sir. I am coming towards it. Please play this.
Was that Badshah? What was troponin like?
Sorry, sir.
The
The troponin was 4.13. Sir, this is the right coronary artery. If we look at the ECG, the elevation were in the inferior lead, sir. But the right coronary artery
Can
is.
you show up
Yes, sir.
left system, please?
यार एक बंदा है जो ये क्यों प्ले नहीं हो रहा?
Yeah, it was simple acute.
यार ये बीच में स्टॉप क्यों हो जाता है? प्ले क्यों नहीं हो जाता?
Let's have a look on the left system again.
Yes, sir. The ECG was showing inferior
Can
lead
you show
elevation.
us another view?
Yes.
Do you have a aleocranial?
नहीं छोड़ो मैं चेंज कर.
So this circumflex is not dominant.
Yes.
So the right coronary artery should be dominant, but this
No, sir,
the right.
Sir, if we look at the LAD is wrap around, sir.
Yeah.
This is type 4 LAD, and the
Circ should
haziness
be circumflex should be crossing LAD in this view if it is to be dominant. It may be co-dominant, and I think we need to have a look on RCA again.
Yes, sir. Sir, look at the LAD, sir. It is
what
wrap
about
around.
inflammatory markers, CRP?
The CRP was raised, sir, but unfortunately, sir, I didn't mention it here.
So what do you think? What happened?
Sir,
What is
this.
the diagnosis?
What about the distal RCA? Is it occluded or what?
No, sir. This is a short RCA, I think. Sir. Look at, sir.
Non-dominant.
The LED, sir, a wraparound LED, and the ECG was showing in ST elevations in the inferior lead, sir. And that lesion is explaining because of the LED is a wraparound, so that is explaining the ECG, sir.
डॉक्टर साहब, जस्ट आउट ऑफ इंटरेस्ट 2 क्वेश्चंस. एक तो ये एक पिक्चर आपकी सेदू टीचिंग हॉस्पिटल शो कर रही है, दूसरा एक और कार्डिक सेंटर का बता
जी
रही है.
सर, एक्चुअली दिस सर ये ऐसा हुआ कि जो पेशेंट इनिशियली आया था तो दिस वाज इन द नाइट, सो द ऑपरेटर डिड इट इन द नाइट. आवर cath lab are closed, sir.
Anyway,
is closed, so
ठीक
the
है.
operator did it in the private setup, but the repeat angio
ठीक ठीक.
performed in our setup.
दूसरा सवाल आपसे ये कि ये आपने लिखा है अपने जो आपकी फर्स्ट स्लाइड थी कि ईसीजी की चेंजेस का आपने बड़ा जिक्र किया और शायद डेंगू के साथ लिंक अप कर रहे थे.
जी सर.
चेस्ट पेन तक तो समझ आ गई, और कोई डाटा में आपकी नजर
Yes.
से कोई चीज गुजरी है कि जो स्पेसिफिक टू डेंगू है जिससे आप इसको इससे लिंक अप कर लें?
Yes, sir. At the end, I have added a slide which correlates the dengue with the SCAD, or the heart involvement, sir. So this was the echo post angiography. So this is the SCAD management according to the ACC. And this case, I will be coming to the conclusion. This case highlights the importance of vigilant monitoring, prompt recognition of the cardiac complication in patients with dengue fever, and an effective management of SCAD using guideline-based treatment. This study proved a 13-fold higher incidence of acute myocardial infarction within 7 days after dengue infection in a large population-based cohort study with other infection control measures, suggesting a causal association. So such injuries must be considered differential when diagnosed acute myocarditis. And sir, basically the SCAD is defined at the narrowing of the artery without any atherosclerotic plaque or without any disease. So this is basically a tear, and the tear can be explained with the dengue infection. Because the dengue virus, सर जो dengue virus होता है वो endoplasmic reticulum के through cells को damage करता है. So this can also damage the heart and the coronary arteries, and this the previous study also suggesting an association between the dengue fever or the myocardium involvement or the SCAD. Doctors who treat dengue patients should remember this. Medical staff should be highly cautious of the cardiac complication that may arise in patients suffering from dengue fever, and at the end, local guidelines and recommendations should be developed for timely management of the cardiac complication in dengue positive patients. That's all, sir. Any questions?